Okay, I think we are live and I think you are able to hear me in a proper manner. Yeah, hello. Yes, I hope I'm audible and visible to you in a proper manner. And I think we are live, so let's start without wasting any further time. Okay, so in today's session, what do we have is we have basically what we are trying to do over here is we are basically trying to kind of revise few important topics for you guys. The timing is like very small. I'll be having this particular session for let's say 45 minutes, 50 minutes or so, and that's what we are going to kind of do in this particular thing. Right now, just to begin with, what do you have here? These particular, okay, let's start with the few topics of general surgery. The general surgery, one of the very important things is about the scalpel blades and the handle for that. Okay, so what is this? This is what is a 11 number knife, which is a stab knife. Okay, so just look at this. Okay, what is this? This is a stab knife. Now quickly, can anybody tell me where exactly do we use this? So the stab knife is basically used when you basically wish to do incision and drainage, or let's say you wish to do a tracheostomy, or let's say you want to kind of what you call have to perform an arteriotomy. Okay, so in these particular cases, what you have to do is you have to kind of use this particular stab knife. Okay, so where do you use a stab knife? Where you want to kind of do all these particular things, right? Okay, all clear? Right now, why so? Because we want to kind of enter into that particular cavity in a decisive manner, and wherever you want to enter into the cavity in one go, there you basically are going to use a stab knife. Out of this, do not forget the tracheostomy. That is an important one. What about this? This is what is called as a D knife. Okay, what is this? This is what is a D knife. This is basically the 15 number plate D knife where this is used. So this is basically used whenever you want to kind of perform some minor surgical procedure. Okay, or wherever you want to basically have a precise incision. Okay, so you want a precise incision. Wherever you want a precise incision, there you kind of use this D knife, or what you call as a 15 number blade. Then what is this? This is what is a 23 number blade. So where do you use this? This is basically used wherever you want to do a debridement. Okay, so where do you want to do is a debridement. Okay, I hope you're able to understand this particular point. Wherever you want to do a debridement, there you basically have to kind of do this. Okay, now notice this. This is what is a BP handle or a barred Parker handle. Now, what is this particular BP handle or the barred Parker handle? So this is basically like third and the fourth. What is the third one and what is the fourth one? So what you need to understand is that knives like let's say 11 and the 15, they are basically mounted on the barred Parker handle 3, and the knife which is basically let's say 21, 22, 23. All these particular things are mounted on the barred Parker handle 4. Okay, so we have a barred Parker handle 3 and 4. Okay, so these are the important things. I hope you have understood this particular point. These are the blades and the handle on which it is basically mounted. Okay, now so this is just what I just kind of told you. This is in the tabular form. Okay, right. Now let's talk a bit about the cautery. So what do you have? You have a monopolar cautery and then you have a bipolar cautery. So what is this? This is what is a monopolar cautery. At least you should know the image of this. Okay, I hope you're able to appreciate the image of this. Okay, what is this? This is what is a patient plate which is going to kind of bring the electric current back into the system. Okay, into the electrosurgical unit. This particular patient plate is going to bring the current back. And what is this? This is what is the monopolar cautery device. Okay, monopolar cautery device. So over here, what you need to understand is that you have a blue and the yellow. So what is this blue? What is this yellow? Yellow is basically whenever you kind of press on the yellow, what you have is a cutting current. Okay, you have a cutting current. Okay, what about this blue? It basically helps you in passing the what you call as a okay, so blue basically helps you in passing. Oh, release this. Okay, so blue basically helps you in basically passing what you call as a coagulation current. Okay, so the blue basically helps you with the coagulation current and the yellow basically helps you with the cutting current. Just give me a minute, I'll be back. Just give me a minute. Okay. Just wait for 1 minute, guys. I'll be back. Just give wait for 1 minute. Okay, you're not able to see me, but just give wait for 1 minute. Okay, so sorry for this kind of interruption in between. So what you need to understand is this blue is basically for the coagulation current. Okay, so blue basically whenever you kind of press on this blue button, what basically comes out is a coagulation current. Okay, so this is something which is very important for you guys. Okay, now what about this? What is this? This is what is a bipolar cautery. In the bipolar cautery, what you have the two prongs. Okay, and you basically hold the tissue in between it. Okay, so you hold the tissue in between it. So what happens is that when you pass the current goes through one and then it comes back through the other one. Okay, so here you do not need a patient plate. Do you need a patient plate in the coagulation current like in the bipolar cautery? No, you do not need a patient plate in the bipolar cautery, but yes, you do need a patient plate in the monopolar cautery. Okay, so this is the basic things which you need to understand over here. Now quickly let's kind of talk a bit about your monopolar and the bipolar cautery. So what are the kind of advantages and the disadvantages of a kind of a monopolar as well as the bipolar ones? Okay, so I'll be kind of quick and I'll be kind of concise. So in the monopolar cautery, what happens is there is a cutting. Okay, so there is a cutting of the tissue which happens because a lot of electricity kind of goes through the tissue, and ultimately what happens is that the tissues get cut. What about the bipolar cautery? There is a coagulation which happens. What do you understand with the coagulation? So what you basically hold the tissue, and when you pass the current, there is like the coagulation happens. It means that the bleeding is basically stopping. Okay, so that is what is a coagulation. Now, what about the lateral spread? What do you think? Lateral spread is more with the monopolar or the bipolar? Now, I'm pretty sure that if you apply your logic, you will say that the monopolar has a more lateral spread, but please try to understand this has the lateral spread is more. Okay, so lateral spread is more in the bipolar cautery and it is less in the monopolar cautery. Lateral spread of the current is basically more in the bipolar as compared to that of the monopolar. Okay, I hope you have understood this particular point. What else? So let's not go into the much more details of it. So there is the time duration and everything, but just try to understand whenever you want to coagulate, or let's say there is a bleeding, what you use is a bipolar, and whenever you want to cut through the tissue, then you basically use a monopolar. Okay, that is what you need to understand. And monopolar means the cutting current. Okay, so we have a cutting current. Okay, so in the monopolar, what you have is a cutting current. Okay, right. Now let's quickly revise the blood products. Okay, so here what you have a blood products. Okay, so let's assume that whenever, let's say, somebody donates a blood, what happens? You can either use that blood like that itself, like you can use that particular blood to transfuse it into some individual, or what you can do is you can break that particular blood into the blood products. So what are the blood products which are available? So you have the red cell concentrate, you have a fresh frozen plasma in the cryoprecipitate, and then you have a platelet. So these are the three main what you call as the blood products which we have. Okay, so what are the blood products? We have a whole blood, red cell concentrate, packed cell volume, all these particular things are there. Then we have a fresh frozen plasma in the cryoprecipitate, these are the other components, and then you have a platelet. So these are the three different kind of blood products which we have right now. When you basically take these blood products, you need to know two things: how do you kind of store it, and at what temperature, and how much period of time. Okay, so the whole blood is basically stored at 2 to 6 degrees Celsius. Okay, so this is basically stored at 2 to 6 degrees Celsius. What is an anticoagulant which we use in order to store the whole blood? So there are two which are most commonly used. One have a CPDA and the SAGM. So what does the CPDA stands for? Citrate phosphate, dextrose, adenine. Okay, so CPDA stands for citrate, phosphate, dextrose, and adenine. And then what is the SAGM? In the SAGM, what you have is the saline, adenine, glucose, and mannitol. So this is what you need to understand over here. Okay, very, very important. What are the anticoagulants which we use in order to hold the red cell concentrate or the PCV or the whole blood? Okay, whole blood also comes under this category only. Okay, now the important thing is for how long you can kind of store it. So if at all you have a whole blood, or let's say you have a red cell concentrate or a packed cell volume, this can be stored for around 5 to 6 weeks. So let's say 35 to 42 days. Okay, so this can be stored for around 5 to 6 weeks, or what you call as a 35 to 42 days. Okay, so that is what you need to understand over here. Now, what about the fresh frozen plasma and the cryoprecipitate? This is stored at minus 30 to minus 40 degrees Celsius. At what temperature do you store it? You store it at minus 30 to minus 40 degrees Celsius. For how long can you store it? You can store it for 2 years. Minus 30 to minus 40 degrees Celsius for 2 years. Cryoprecipitate fresh frozen plasma. What about the platelets? So the platelets can be stored at room temperature. You can store it at the room temperature, and you have to kind of store it in an agitator, because if you just keep the bags on the at the room temperature, the platelets are going to get clumped with each other. So you have to kind of store it on the agitator. And what you need to understand is that the shelf life of the platelets is how much? The shelf life of the platelets is 7 days. Okay, so 7 days is the shelf life for the platelets. I hope you have understood this particular point. Very, very important. So blood and the blood products are absolutely important. I hope you have understood this point. Okay, now coming to the next, ulcers. Okay, so ulcers are absolutely important for any MDS exam you take, either it's a NEET PG or INI or whatever. Ulcers are absolutely important. Okay, so let's talk about the ulcers a bit. Okay, now in this there are the different edges and the so margins of the ulcer and everything. So we have a sloping ulcer. So what is a sloping ulcer? Sloping ulcers, or this is what is the slope which is kind of present. This is present in the healing ulcer. So let's say the varicose vein. Okay, so the venous ulcers. Venous ulcer is basically a sloping ulcer, and this is how you basically kind of have it. Okay, so the venous ulcer, healing ulcer, it's a sloping ulcer. Then what we have is a punched out ulcer. What about this particular punched out ulcer? Punched out ulcer, right angle. Okay, so this is what is in an arterial ulcer or a syphilitic ulcer. Okay, so syphilitic, trophic ulcer, arterial ulcer, all these are the what you call as a punched out ulcers, which are basically at a right angle. Okay, so if at all the arterial supply is not there, then what you basically get is a punched out ulcer. In the peripheral vascular disease, PVD, what are you going to get is a punched out ulcer. Then we have an undermined edges. What do you understand by the undermined edges? So I hope you're able to appreciate the edges are like this. Okay, so this is what is an undermined edges. Okay, so this undermined edges, this is what is basically present in the tuberculous ulcer. Okay, so the tuberculous ulcers has a undermined edges. Okay, I hope you are able to understand this particular point, guys. Okay, then what you have is a rolled out ulcer. Okay, so we have a rolled out ulcer, which is basically a feature of your basal cell carcinoma. And what we also have is we have an everted edges. Okay, so we also have everted edges, everted edge with indurated base. Okay, if at all you give you this, what are they talking about? Everted edges with an indurated base. They're basically trying to talk to you about the squamous cell carcinoma. Okay, so where do you get this everted edges with an indurated base? This is what you basically get in the squamous cell carcinoma. I hope you are able to appreciate these particular things in a decent manner. Okay, now coming to this. Okay, so this exam, like this image, I want you guys to answer, guys. Okay, so whoever you are on the, like whoever is kind of connected me at this point of time live, okay, please try to answer. What do you think? What is this type of an ulcer? Just look at the location and tell me, what are you dealing with? Are you dealing with an arterial ulcer, venous ulcer, tuberculous ulcer? What are you dealing with? What do you think? What is this? Okay, so this is what you're basically dealing with is an arterial ulcer. Okay, so what is this? This is what is an arterial ulcer. Okay, so you are basically dealing with an arterial ulcer over here. Okay, now why I'm saying this is an arterial ulcer? Look at the kind of a location. The location is basically on the lateral aspect of the foot. Are you able to appreciate the skin, the surrounding skin? The surrounding skin of this particular place is very thinned out. There's a loss of hairs and everything. So what is this? This is what are you basically facing over here? This is what is an arterial ulcer. Okay, very important thing. Okay, now coming to this. Okay, so what is this? This is what is a venous ulcer. Okay, so this is a characteristic location of a venous ulcer. Okay, where it is present? This is basically present in the gaiters area. Okay, so in the gaiters area, what are you basically having is a venous ulcer. Okay, I hope you have able to understand this particular point, right? So in the gaiters area, this is what is a venous ulcer. Okay, right. Now, I'm really sorry guys, my pen is kind of giving me some problem. Just give me a minute. I'll figure it out. I know it's kind of wasting your time already. The session is only of 45 minutes or so, but I'll just take, let's say, 4-5 minutes and I'll try to sort this off. Okay, so just I'll connect back with you after 5 minutes. If you really wish to kind of watch this, just wait. Okay, it's really just wait, just for 5 minutes. I'll be back in 5 minutes. Okay, so till this particular pen issue is kind of getting sorted, what I'll do is I'll just talk to you. Okay, I know you don't want to listen to me just kind of give you Fukut ka gyan, but I'll just do that for a couple of minutes. Okay, now I just want to have a word with you guys. Okay, so what you need to understand is that I hope that all of you who is watching this particular thing are preparing for one or the other kind of the MDS exam. So either you're preparing for, let's say, the NEET MDS or the INI MDS or whatever. Okay, now general surgery, yes, there are many questions which, like, not many, I would say, but yes, there are few questions which come in your exam. Okay, and you definitely need to read few of the topics. Okay, so out of, let's say, whatever I have noticed, let's assume that there are 5 questions which are going to come. At least 3 questions are going to come from a commonly asked topics, and a couple of questions are going to come from absolutely out of nowhere. So do not forget to read the GCS, Glasgow Coma Scale. Do not forget to kind of read the ulcers. Do not forget to read the next phalanx, like the thyroglossal cyst. All these things are very important for you guys. They keep on asking you this in one way or the other. Another important thing, very important thing rather, which they keep on asking you is the hemostatic agents. Okay, so do read that particular thing in detail, because that is kind of given at very few places. Okay, so you do need to kind of remember that and kind of read that. Okay, now the what problem is happening at this point is my pencil is getting charged. I don't know why it's kind of got discharged. So what I'll do is I'll just kind of cover a rapid fire with you guys. Okay, so if you can just kind of put your answers on the kind of comment box. It will just take a couple of minutes. My pencil will get liquidly charged for me to kind of cover the entire session, right? Okay, now if I ask you what should we cover? Okay, let's kind of cover the topic. Which topic do you want to cover? Okay, okay, let's what, come on, any topic, man. Okay, let's talk about the thyroid malignancies. Okay, because that is again a very, like, a bit of an important thing. So if I ask you what is the most common thyroid malignancy, okay, put your answers on the comment box. Okay, do not kind of do that. Do put your answers on the comment box. Okay, I'll just keep on talking, because if I wait for your answers, obviously, like, the session will not give you that much of value. So the most common thyroid malignancy is basically a papillary carcinoma of thyroid. Okay, now if I ask you what is the risk factor for the papillary carcinoma of thyroid, the risk factor for the papillary carcinoma of thyroid is the radiation to the neck. Okay, that is one of the important kind of risk factors, and a long-standing thyroglossal cyst, that is a second most important risk factor. Usually the demography of the papillary carcinoma of thyroid is, it is more common in the females as compared to that of the males. Okay, so that is what you need to understand. Now, how will the patients present to you? Patients will present to you with a nodule, either not in the midline, usually it's going to be a lateral to the midline, but the characteristic description would be that this particular nodule is moving on deglutination. So when you swallow, this particular nodule moves. Now you understand my point. Now, don't consider that every time the nodule is going to move, that is going to be a kind of a thyroglossal cyst. No. So if at all there is a nodule, or let's say cyst, which is going to move with kind of deglutination as well as on the protrusion of the tongue, then it is a thyroglossal cyst. But even a simple thyroid nodule can move with the deglutination. Okay. Now, this is how the presentation is going to be. That's all fine. Now, if at all you want to kind of diagnose it, okay, so how do you kind of diagnose the papillary carcinoma thyroid? FNAC. Do an FNAC. On the FNAC, what are you going to get? On the FNAC, you're going to get what you call as a orphan NEI nuclei. Okay, so do not forget this. The characteristic feature on the FNAC is orphan NEI nuclei. What else do you get? You get the stomata bodies and the pseudogrooving. Pseudogrooving you can forget, not an issue. Do not forget the orphan NEI nuclei. Do not forget the stomata body. So these are the two important things what you basically get on your FNAC. Okay, on FNAC, what do you get? You get the stomata bodies and you get your orphan NEI nuclei. And what about the management of this? So total or a near total thyroidectomy. Okay, so that is what is the management of your papillary carcinoma of thyroid. Okay, now I can see that you guys are not liking it, because I can see so many people's kind of dropping it out. So I understand that, no issues. So what I'll do is I'll just I think my Sorry for this, but yeah, I think my pencil has now been adequately charged, and I'll kind of revert back to my kind of slides, and I'll cover whatever the topics I had to cover. Okay, to begin with. Okay, so what is this? What is this? This is what is your what you call as a gaiters area. Okay, so this is the medial part of the leg. So medial lower kind of 1/3 to 2/3 part of the leg. So this is what is your gaiters area, and this is what is a characteristic location for what you refer to as your venous ulcer. So this is what is a characteristic location for your venous ulcer. Okay, I hope you have understood this particular point. Right, now what is this? Okay, so if I kind of give you a question, if I give you a question and if I tell you that, you know what, there is a patient who is coming to you with a chronic non-healing wound. Okay, so there's a patient who's coming to you with a chronic non-healing wound. Okay, so patient has had this particular chronic non-healing wound, or let's say chronic non-healing ulcer. Okay, and if I ask you what is the next step in the management of this particular patient, the next step of the management, this is an important clinical scenario, guys, very very important clinical scenario. So the next step in the management of this particular patient is a biopsy. So you have to kind of take a biopsy. Why do you want to take a biopsy? Because by taking a biopsy, you want to rule out malignancy. Okay, you want to rule out malignancy. What kind of malignancy do you want to rule out? So the most common malignancy which happens in the chronic non-healing ulcers is squamous cell carcinoma. Okay, so what do you want to kind of rule out is squamous cell carcinoma. So that's what you have to kind of rule out over here. Okay, so what you basically rule out is a squamous cell carcinoma. Okay, so what is this? Can anybody name this for me? What is this? This is what is your Marjolin's ulcer. So the characteristic thing about the kind of Marjolin's ulcer is that it is going to happen in the chronic non-healing burns wound. Okay, so it is going to happen in the chronic non-healing burns wound. Okay, yeah, that's where it's going to happen. Okay, that's the first thing. And what is the what do you call it, the like, what is this? So this is like, if at all you take a biopsy, what you're going to have, you're going to have what you call as a squamous cell carcinoma. Okay, so what are you going to have is a squamous cell carcinoma over here. Okay, if you take a biopsy from here, then what you're going to have is a squamous cell carcinoma. So this is what is a Marjolin's ulcer, very very important. Okay, now let's kind of talk about the sutures a bit. Okay, so in the sutures, what you need to understand is that, okay, there is a monofilament and the multifilament and all those things are fine, but what you have is, you have either a absorbable and the non-absorbable sutures. Okay, now what is the absorbable sutures? Absorbable sutures can be either natural or they can be synthetic. Okay, so the absorbable sutures can be natural or the synthetic. Now what is a naturally occurring absorbable suture? So the characteristic example is the catgut. Okay, now a catgut is important because, okay, so it's important. So let's talk about this. Okay, so from where it is isolated, catgut is basically isolated from the submucosa of the intestine of sheep. Okay, so catgut is basically isolated from the submucosa of the intestine of the sheep. Very 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 important. Okay, so that is what you need to understand. Why submucosa? Because submucosa is the toughest layer of the intestine. Okay, so submucosa is the toughest layer of the intestine and the catgut is basically isolated from there. Okay, now what you need to understand is that, okay, catgut, what is the main problem with the catgut? Is the absorption time. Okay, so the absorption time for the catgut is basically what you call as, let's just like 5 to 7 days. Okay, 5 to 7 days is the absorption time for this particular catgut. Okay, so after that it's going to kind of disappear. That's why it's not that important, right? That is why, in order to increase the absorption time, what did we do? We basically coated it with the chromic acid. Okay, so the coating of the chromic acid which we kind of put on this particular catgut, this is what is referred to as your chromic catgut. Okay, I hope you are able to understand this particular point. So catgut, and then we have a chromic catgut. What is a chromic catgut? On the catgut you have put the coating of a chromic acid. Okay, so that is what is a chromic catgut. I hope you have understood this particular point. Right, now let's talk about the absorption. So as I told you, it is a naturally occurring absorbable suture. So naturally occurring. Okay, so because it is a naturally occurring absorbable suture, how it is kind of absorbed, like it's not going to be a magic, right? So how these particular sutures are absorbed? These are absorbed by the process of what you call as an enzymatic degeneration. I understand my point. So the catgut is basically absorbed by the process of enzymatic degeneration. Enzymatic degenerations. Okay. So whenever there is information of like enzymes kind of come into play, what happens? It's an exothermic reaction. And because it is an exothermic reaction, what is it going to cause? It is going to cause a lot of induration and kind of fibrosis and everything, right? So that is what you need to understand over here. Catgut, naturally occurring absorbable sutures, enzymatic degeneration. That is what you need to understand over here. Understood? Right. Now coming to the synthetically occurring kind of absorbable sutures. So what are the synthetically occurring absorbable sutures? We have the two categories of this, monocryl and the vicryl. What is the monocryl? Monocryl, the name or the scientific name or the chemical name rather for this is polyglycaprone. Okay, so that is what you need to understand. It is a polyglycaprone. And what is a kind of vicryl? It is polylactic acid. Okay, so that is what you need to understand over here. These are the chemical names. Okay, now the difference between monocryl and obviously we have a PDS as well, so I'll talk to you about the PDS as well. Okay, so these are the three main synthetically occurring absorbable sutures which we have. Now monocryl is monofilament, vicryl is a multifilament. That's all fine. Now if I ask you what is an absorption time for this? Okay, so what is an absorption time for this? Absorption time for these two is 60 to 90 days. Okay, so what is an absorption time? It is 60 to 90 days. Absorption time for these two is 60 to 90 days. What about the PDS? The absorption time is 180 days. So PDS is basically called as a delayed absorbable suture. Okay, what is this? This is what is called as a delayed absorbable suture. I hope you are able to understand this particular point. PDS is a delayed absorbable suture, and these two are basically having a 60 to 90 days kind of a thing. That's all fine. Now what is the process of absorption in the monocryl and the vicryl? They are the synthetically occurring absorbable sutures, right? So they are basically absorbed by the process of hydrolysis or phagocytosis. Okay, hydrolysis and the phagocytosis. Okay, so this is basically absorbed by the process of hydrolysis and phagocytosis. Okay, I hope you are able to understand this particular point. Now coming to the non-absorbable sutures. In the non-absorbable suture category, what do we have? We have a naturally occurring non-absorbable and synthetically occurring non-absorbable. What is a naturally occurring non-absorbable suture? So we have silk. Okay, as simple as that. Silk. What is a synthetically occurring non-absorbable suture? So we have a proline. What is this particular proline? Proline is polypropylene. Okay, proline is polypropylene. And then we have a nylon, which is polyamide. So nylon is something which you basically kind of use to kind of take the skin stitches. Okay, but the actual name, it's not nylon, it is polyamide. Okay, and the proline is basically polypropylene. Okay, so these are the two synthetically occurring non-absorbable sutures. Okay, I hope you have understood this particular point. These are the important points regarding the sutures which you need to understand. Now this is a simple anatomy of like the simple diagram of the basics of the anatomy of the thyroid gland, but there are too many things to kind of learn from here. So what I'm going to kind of focus over here is a couple of things. Okay, so first of all, let's talk about the this particular superior thyroid artery and the inferior thyroid artery. Okay, so where do you ligate it? Okay, so whenever you are undergoing a thyroidectomy, so let's assume that there is a patient who is undergoing a thyroidectomy. Where do you ligate this external, like the superior, the STA is superior thyroid artery. Okay, ITA is the inferior thyroid artery. Where do you ligate it? Do you ligate it close to the gland or do you ligate it away from the gland? So the thing is that the superior thyroid artery is basically ligated very, very close to the gland. Why? Okay, so please, first thing what you need to understand is that the superior thyroid artery is ligated close to the gland. Why? Because you want to prevent the injury. You want to prevent injury to the superior laryngeal nerve, or rather the external branch of superior laryngeal nerve. So superior laryngeal nerve has two branches. Okay, so please do remember, superior laryngeal nerve has two branches, external branch and the internal branch. And what do you want to prevent? You want to prevent the injury to the external branch of the superior laryngeal nerve. Okay, understood? Now okay, now if at all this is injured, if the external branch of the superior laryngeal nerve is also called as an external laryngeal nerve. Okay, so this is also referred to as your external laryngeal nerve. Okay, so if at all there is an injury to the external laryngeal nerve, okay, what is going to happen in this particular patient? Okay, so the external branch of the superior laryngeal nerve, this is what is supplying the cricothyroid muscle. Okay, so this external branch of the superior laryngeal nerve, or the external laryngeal nerve, this is basically supply the cricothyroid muscle. Okay, so this is what is supplying the cricothyroid muscle. And what is the function of the cricothyroid muscle? The cricothyroid muscle is the for tensor of the vocal cord. Cricothyroid muscle is the tensor of the vocal cord. Are you understand my point? So external branch of the superior laryngeal nerve is supplying the cricothyroid, and it is the only tensor of the vocal cord. So if at all it is injured, what is going to happen? There is going to be the loss of pitch of the sound. Okay, so whatever these high notes then musicians and everybody is kind of able to kind of hit, so that they will not be able to kind of hit. You understand my point? So that is what is the going to happen if at all the external branch of the superior laryngeal nerve is kind of damaged. I hope you have understood this point. Okay, now coming to the okay, so let's talk about the recurrent laryngeal nerve first. Okay, so recurrent laryngeal nerve. Okay, so recurrent laryngeal nerve, what is the function of this particular nerve? This supplies all the other muscles of the larynx. Okay, now what you need to understand about this, if at all, let's say there is a injury to the recurrent laryngeal nerve, it can be the unilateral or it can be bilateral. Okay, so what is going to happen if at all there is an injury to the recurrent laryngeal nerve? So please understand, if at all there is a bilateral injury to recurrent laryngeal nerve, the patients are going to land up into respiratory distress. Okay, the patients are going to land up into respiratory distress. But if at all there is a unilateral injury to the recurrent laryngeal nerve, then there's going to be the voice fatigue. Okay, then there's going to be a voice fatigue. Are you understand my point? So please do remember this. Bilateral injury to the recurrent laryngeal nerve, respiratory distress. Unilateral injury to the kind of recurrent laryngeal nerve, not the respiratory distress, it is going to be a voice fatigue. I hope you have understood this particular point, guys. Okay, now if I ask you which is the most common injured nerve during thyroidectomy, most commonly injured nerve during thyroidectomy, the answer is, what is the answer? It is the external laryngeal nerve. Okay, what is it? It is an external laryngeal. This is the most commonly injured nerve. It is not the recurrent laryngeal nerve. You might tend to mark it as a recurrent laryngeal nerve, but that is not the most commonly injured nerve during thyroidectomy. It is the external branch of the recurrent laryngeal nerve. Now, coming to this inferior thyroid artery, where do you like it? Do you like it close to the thyroid gland, or do you like it away from the thyroid gland? Okay, so please try to understand over here that the inferior thyroid artery is again ligated close to the thyroid gland, And what is the reason for that? Why it is ligated close to the thyroid gland? Because to prevent ischemia to parathyroids. Okay, because you want to kind of prevent the ischemia to all the parathyroids. That is the reason why you basically ligate it close to the thyroid gland. So what you need to understand is that, let's assume this is a thyroid gland. So we have this inferior thyroid artery. Okay, yes, it is going to supply the thyroid, no doubt, but it is also going to supply all the four parathyroids. Okay, so all the four parathyroids are the ones which are basically supplied by the inferior thyroid artery only. I understand my point. So we have this particular parathyroid gland over here, we have a parathyroid gland over here, we have a parathyroid gland over here, we have a parathyroid gland over here. You understand my point? Okay, so all the four parathyroids are supplied by the like the branches of the inferior thyroid artery only, and because you want to prevent the injury to them, you basically ligate the inferior thyroid artery very close to the gland, because by this time the branches which were to be given for the parathyroid gland, they are already kind of given. Okay, so this is very important, which you need to understand. Okay, now let's talk about this. Okay, so what is this severe maxillofacial injury? Now, if at all there is a patient with a severe maxillofacial injury, there are two things which you need to remember. One is, what is an emergency airway, and what is a definitive airway. Okay, so if at all, let's say there is a patient who is basically having a severe maxillofacial injury, orotracheal intubation, single gentle lateral can be given, but not preferred. Nasotracheal intubation is absolutely contraindicated. Why is the nasotracheal intubation absolutely contraindicated? Because if at all there is a severe maxillofacial injury, there can be the fracture of the base of the skull. Okay, severe maxillofacial injury, fracture of the base of the skull, and if at all you try to do a nasotracheal intubation, what is going to happen? This particular tube might cause injury to the brain parenchyma, which you don't want. Okay, you understand my point? So that is the reason what you need to understand. Nasotracheal intubation is absolutely contraindicated. Orotracheal intubation, a single gentle attempt can be kind of tried. Okay, now what is an emergency airway and what is a definitive airway? So please try to understand, in the patients with the severe maxillofacial injury, the emergency airway is cricothyroidotomy. And what is a definitive airway? Definitive airway is the tracheostomy. So these are the important MCQs which they ask you. Cricothyroidotomy, there is a cricothyroid membrane. You can just kind of put a needle over here and you reach into the kind of a trachea, and yeah, then you can establish the airway. But the drawback of the cricothyroidotomy is that it is going to be effective only for 30 minutes. After 30 minutes, the CO2 retention starts, and after that, this is going to be of no use. Now you understand my point? On the other hand, the tracheostomy, that is a kind of a long-term definitive airway in the patients with the severe maxillofacial injury. I hope you have understood this particular point. Very, 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 very important. Okay, understood, right? Now coming to this. Okay, so what is this? This is what is a GCS. Okay, so this is what is a GCS, Glasgow Coma Scale. Very, very important. Okay, so what is this particular GCS or the Glasgow Coma Scale? Okay, so let's kind of talk about this now. Okay, now what you need to understand over here is that yeah, so the GCS basically has like the three things. Okay, so eye-opening response, verbal response, and kind of a motor response. Okay, so these are the three things which you basically have in this. Okay, so what is about the eye-opening response? Okay, so eye-opening spontaneously to the painful commands, to the painful stimulus, and do not open at all. You understand my point? So spontaneous to the okay, let's kind of take it step by step. Okay, so the GCS, what we have eye-opening response, verbal response, and the motor response. Eye-opening response, the maximum kind of value which you can get is the 4. So what is 4? 4 is that when you go to the patient is opening the eyes spontaneously. That is the GCS of like eye-opening response of 4. Then if at all you go to the patient is kind of not opening the eyes, but when you call the patient basically opens the eyes. So to the verbal command, if at all the patient opens, that is a 3. Okay, then to the painful stimulus, even on the verbal command, if at all the patient is not able to open the eyes, then you pinch the patient. You give the painful stimulus to the patient, and on that, if at all the patient open the eye, that is what is the eye-opening response of 2, and 1 means no response at all. No matter what you do to the patient is not opening the eyes. That is what is the eye-opening response of 1. Okay, understood? Now coming to the verbal response. Now, what about the verbal response? If you go to the patient, if you talk to the patient is well oriented to the time, place, and person, that's great. Verbal response of 5. Okay, if you go to the patient, you talk to the patient is like confused. Patient, okay, you ask him, where are you? Oh, maybe I'm in the hospital, maybe I'm at home. Okay, if at all the patient is confused, then there is a kind of a verbal response of 4. Then what is a verbal response of 3? Whatever the patient is saying, it makes sense, but it is inappropriate to the conversation which you're having. You understand my point? So you ask the patient something, and what you need to understand over here, that the patients are having and inappropriate words. Okay, inappropriate words or the words only. Okay, so inappropriate word means you ask the patient something, but whatever the patient is saying, it makes some sense, but it is not relevant to the conversation which you're having with that particular patient. Then what you need to understand over here is if you talk to the patient and the patient is just creating sounds, burp, or something like that, it doesn't mean anything. Okay, so incomprehensible sound, that is what is a verbal response of 2. Sounds only is basically means incomprehensible sound. It means that whatever the sounds the patients are kind of making, it doesn't hold any meaning in any of the languages. That is what is a verbal response of 2. What is 1? 1 means no sound at all. So you kind of go pinch the patient, whatever you do, but there's no sound at all. So that is what is basically the verbal response of 1. Okay, and then we'll talk about the tracheostomy patients in a bit. Just give me a minute. Okay, then what about the motor response? In the motor response, if you go to the patient, you ask the patient to kind of lift the hands and the legs and everything, the patient obeys your command. Motor response of 6. If you pinch to the patient and the patient brings the hand towards that is what is localizes pain. So that is a kind of motor response of 5. Then you pinch to the patient and patient takes the hand back. Withdrawal response. motor response of 4. If at all there is an abnormal flexion, that is what is a motor response of 3, abnormal extension, motor response of 2, and no motor response at all, that is a motor response of 1. Are you understand my point? So this is what is the GCS, very, very important. Now coming to the patients who are tracheostomized or intubated, are you able to kind of know the verbal response of these particular patients? No, not really. Okay, so you do not assume it to be 1, you do not assume it to be 5, you do not assume that. Whenever you are calculating the GCS for these particular patients, write VT or VNT. What do you understand by T or NT? It basically, NT basically means non-testable or tracheostomized or whatever. You understand my point? So some patients, some people say that, you know what, tracheostomized patients verbal response of 1. No, not really. Patient is not able to speak because you have put a tracheostomy tube in the patient. You understand my point? You're not able to assess the verbal response of this particular patient. So it is VNT, non-testable. Very, very important. Okay, I hope you have understood this particular point, guys. Very, very important. Okay, now quickly coming to this. Now again, it's kind of written on the screen, but what is this? This is what is a non-contrast CT scan of EDH, extradural hemorrhage. So one of the important images for you guys. So investigation of choice for the head injuries, non-contrast CT scan. And what are you basically going to see over here? This is what is a biconvex opacity. So what are you seeing? You're seeing a biconvex opacity. So biconvex opacity is basically seen in the patients with the EDH, extradural hematoma. Why does this particular thing occurs, the EDH? It occurs because of the injury to the middle meningeal artery. Okay, so why does this thing occurs? This occurs because of the injury to the middle meningeal artery. EDH occurs because of the injury to the middle meningeal artery. There's accumulation of blood below the dura mater. Okay, in these particular patients in the EDH, the patients may have something which is called as a lucid interval. What is this lucid interval? Lucid interval means that after the trauma, the patient fell down, patient becomes unconscious, then the patient again regains consciousness. Patient is kind of conscious for some period of time, and after that patient again becomes unconscious. So this period of time in which the patient was conscious, this is what is called as a lucid interval. I hope you have understood this particular point. Unconscious, conscious for a period of time, then again unconscious. So this is what is called as a lucid interval, which is associated, which is basically seen in the patients with the EDH, extradural hematoma. How do you manage these particular patients? You do a burr hole. Okay. Now, important and the another thing which you need to understand is that what is going to be the clinical features in these particular patients. So in these particular patients, what happens to the pupils? The pupils, they basically kind of contract, non-reactive pupil on the same side or the opposite side. So pupils, they contract on the same side. Okay, pupils contract on the same side. And what about the like weakness of the arms and legs and everything? So contralateral hemiparesis, ipsilateral contracted pupil, contralateral hemiparesis. Are you understand my point? This is what you need to understand in the patients with the EDH. Ipsilateral on the same side, contracted pupil, on the opposite side, weakness of the legs and everything. Okay, so that is what you need to understand. Now, what is this? This is what is a non-contrast CT scan of SDH, subdural hematoma. Okay, SDH. Okay, so over here, what you had a lens-shaped opacity, biconvex opacity. Here, what do you have? You have a concavo-convex opacity. Concavo-convex opacity, that is what you basically see in the subdural hematoma. Why do this particular subdural hematoma occurs? This occurs because of there is an injury to the bridging veins. Okay, to the bridging veins. To the bridging veins, if at all there is an injury, the patients basically land up into subdural hematoma. There is a blood which is getting accumulated between the dura mater and the arachnoid mater, subdural, below the dura mater. Okay, so I hope you've understood this point. This is what is a subdural hematoma. Okay, yeah, that's all about this particular session which I wish to have with you guys. I obviously have not covered all the topic, but this was just a glimpse of whatever the important topics which you can kind of cover for your exam. Yeah, I will kind of end this particular session in a couple of minutes now. And what you need to understand more thing is that we have covered this particular thing in the rapid revision course as well. So if you wish, you can definitely go and check that particular thing. But yeah, like these are the few of the important topics which I feel that you guys should know. Okay, apart from that, what I told you, the hemostatic agents, yes, definitely that is very, very important. Head and neck malignancies I have not covered over here. Yeah, like obviously all the topics are important because frankly general surgery, not a lot of courses there for you guys, but these are the absolutely must know topics. For example, the ulcers, the GCS of the patient, absolutely must know. Okay, so yeah, that's all for today's session, guys. I hope you had like gain something out of this particular session. See you soon, maybe in few days or so. Okay, take care. Bye bye. Good night.